of the things that I have appreciated throughout all of these years that I have been working on health disparities is that it is possible to overcome the barriers of access to care if we can change a paradigm, because the prevailing paradigm is what I call, and you mentioned, the waiting mode. It is when people are in need of services, they have to go somewhere to receive the services. It is uh, uh, when they have to wait to go for services, usually the symptoms are set, there are complications that ensue, and normal function at many levels is by then lost. Contrast that with the seeking mode, which is we go to them, where they live, where they work, where they congregate, and we offer services at the point of need.
Hello and welcome. You're listening to the Health Disparities podcast from Movement is Life. I'm Dr. Zachary Lum, Movement is Life Steering Committee member and Assistant Professor of Orthopedic Surgery and Chief Wellness Officer at the University of California, Davis. When it comes to addressing health disparities, it is critically important that healthcare providers and researchers take a proactive approach to identify those who need care and take time to build trust with the communities we aim to serve. It's truly my honor to be joined today by Dr. Sergio Aguilar-Gaxiola, Founding Director of the Center for Reducing Health Disparities at UC Davis. Dr. Aguilar's work focuses on health disparities, mental health in underserved populations, community-engaged research, and Latino health. Dr. Aguilar, welcome to the Health Disparities podcast. Thanks for being here.
Well, thank you so much, Dr. Lum. I'm honored actually to be joining you. I want to congratulate you for the Health Disparities podcast. I have been listening to some episodes, and boy, I think that you are doing a great service in this space.
Thank you so much for that. Now, before we begin our conversation, I do want to put a plug in for our upcoming Movement is Life annual summit. This year's theme is Combating Health Disparities, the Power of Movement in Community. The conference will take place, it's in Washington, D.C. on Friday, November 14th. It's an incredible event, bringing together stakeholders from diverse backgrounds to discuss equity disparity challenges and their actionable solutions. Just for the audience, we hope you can join us. Please visit our website, movementislifecommunity.org, for all the details. Now, with that, let's begin our conversation. Dr. Aguilar, before we dive into the specifics of your work, can you share with us a little bit about your background and what made you interested in addressing health disparities in underserved communities?
Yes, that has been a lifetime interest of mine. My training, I trained as a physician, but I also did a master's and a PhD at Vanderbilt University, and a couple of years, including a postdoc at UC San Francisco. And it was focused, actually, my PhD is in clinical community psychology. And I have been working with communities, not on communities or even in communities, but with communities for decades. And I don't know. Sometimes I think that is in my DNA. But let me tell you that really has been a very mission, a very important mission in my life, actually. Now I can tell you that my mission is through the Center for Reducing Health Disparities that I founded and started at UC Davis 20 years ago. It is to serve the underserved. As simple as that, and there are historically underserved populations that we have been focused on. So it is like immigrant populations, farm workers, like other populations that usually don't have access to care. Those are the populations that I have been interested and committed to work with.
Yeah, thank you for that. Since you did talk about the Center for Reducing Health Disparities at Davis, can you tell me some of the key initiatives that the center has been very proud about?
Yes, absolutely. One thing that I want to emphasize is that the work that we do and have done for these 2 decades at the Center for Reducing Health Disparities has been primarily focused on solutions to advancing health and mental health equity. Uh, you know, Inequities have existed for forever, I would say. Now that we have better ways to uh, to uncover them or to study them, it is very clear that there are disparities or inequities, certainly in healthcare. And we made the strategic decision at the center to really not to continue to define health disparities, although we do that as well, but primarily to focus on on solutions to advancing health and mental health equity. And we do it primarily through community engaged approaches, working with communities and working with different groups. And as you asked me, what are some of the accomplishments that we have? I would like to mention that we work, for example, for 8 years with a county. It's called Solano County. It's close to San Francisco. It's close to Sacramento County as well, where I reside. And the leadership of the county came to speak with me. He knew about the work that I do. And he and 3 other leaders of the county came to speak with me and my team also back in 2014. And they said, we want to explore if you would be willing to work with us, because we have been working for 3 years with community leaders to address the disparities that 3 populations, and they focus on those 3 populations, Latinos, Filipinos, and LGBTQ. And he said, we have been working through this cultural competence work group to address their needs and increase the access to care. And he said, but we haven't been able to do that. Would you be willing to help us? And of course, we jumped to that opportunity, and we worked the almost 2 years without any pay, because we were so fascinated and committed. And then they funded us. So we worked for about 8 years
Wow.
closely with them. We officially started in January of 2016, ended up, almost 6 years later. And what I'm happy to share with you, Dr. Lum, is that we documented that it is possible to advance mental health equity, primarily with those three populations that they wanted us to focus on. But it didn't stay there, because it is like Um, you know, other populations, African Americans, whites, and also Native Americans, were also increasing the use of services, mental health services, in the county. Uh,
Yeah,
so,
uh, you've done a lot of work just to kind of talk a little bit about that mental health. You've done a lot of work, extensive amounts with mental health in Latino communities.
mhm,
You were the on-site principal investigator for the Mexican American Prevalence and Services Survey, which was the largest mental health study conducted in the United States on Mexican Americans.
mhm.
Can you speak a little bit about that? Maybe what you learned through the research and about the insight on that study.
Yes, absolutely. Well, this is a project that we continue to call the Mexican American and Prevalence Services Survey. And we focus on people of Mexican origin, both that were born in the US, but also those who were born in Mexico. And we included a sample of over 1,000 farm workers, actually. This was done in Fresno County. For the audience, Fresno County is at the heart of the Central Valley, and it is an area notable, among other things, for being the food basket of not only California but the nation. Through the Central Valley corridor is lots of agriculture, but also there are documented disparities in access to health care and mental health care as well.
Hmm.
So I joined hands with uh, esteemed colleagues uh, who we collectively got funding from the National Institute of Mental Health for 5 years. And I conducted a study in Fresno County, and a little over 3 decades ago, it was a population-based study. And what we did was to study prevalence rates, primarily of mental disorders, including substance abuse, but also chronic health conditions. And something that I want to highlight is that we also very carefully studied the patterns of service utilization. Who was using services, who wasn't using services, who started using services but they stopped using the services. And also we look at risk and protective factors, and we look at the burden of disease as well. And one of the highlights of that project is that I came to appreciate, not so much, although that is important, the prevalence rates, let's say, of depression, anxiety disorders. I mentioned substance use, but the big story was the underutilization of services. Just to give you a sense, uh, of those who met criteria for one or more mental disorders, one of three of the US born people of Mexican origin were using any of the services comprehensive uh, assessment that we did of various services from the general medical sector, the specialty mental health care sector. We studied the other professionals, we included the informal sector like curanderos, folk healers, etc. So just picture this: 1 out of 3 of the US born people of Mexican origin was using one of those or more of those services. 1 in 6 of those who were born in Mexico, and less than 1 in 10 of the farm workers. And guess what? Those disparities haven't changed. Actually, if anything, I'm afraid that they have been even more pronounced at the present time. And so we studied also the barriers of access to care and documented that. And definitely those barriers continue to exist. Like, for example, not being able to get services in Spanish, or lack of transportation to go to the services, or the services that are offered Monday through Friday, 8 to 5, when many of these populations are working, and when they need to go for services, they lose a full day of earning, you know, and it is very challenging for many of them to navigate the systems. So they really miss a full day of pay, which they cannot afford.
Correct. Yeah, totally agree. Yeah, I totally can see why it seems like every major academic investigation that you do kind of reveals something and kind of leads down to the next career path, which you've so enlightened us about, and myself specifically. It sounds like those workers, that's why they wouldn't seek care, because they weren't able to afford it financially or what have you.
Mhm.
And to that same vein, or to take that to the next step, it seems like it would be prudent to maybe bring that care to them. And so you talk a little bit about this, and your concept for healthcare organizations is that they need to be more proactive in providing care to their um, patients, specifically that you would rather be proactive in identifying people who need these care or this care, rather than having these patients wait until they become very ill and sick. Can you talk to me a little bit about this concept of seeking versus waiting? What does that mean to us or to yourself
Yeah,
about healthcare?
absolutely. I'm glad that you are asking that, because one of the things that I have appreciated throughout all of these years that I have been working on health disparities is that it is possible to overcome the barriers of access to care if we can change a paradigm, because the prevailing paradigm is what I call, and you mentioned, the waiting mode. It is when people are in need of services, they have to go somewhere to receive the services. And it is uh, uh, when they have to wait to go for services, uh, usually the symptoms are set, there are complications that ensue, and normal function at many levels is by then lost. Contrast that with the seeking mode, which is we go to them, where they live, where they work, where they congregate, and we offer services at the point of need. We have the technology to do that, actually. We did that out of our center, especially during the pandemic. When we took free antigen tests, vaccines, we did test to treat, working with fairly qualified health centers, that when we saw that someone was positive to COVID, right on the spot, we connected the person, if they wanted to receive services on the spot, with a primary care physician from two of the fairly qualified health centers that we work with. So picture, that the barriers of access to care that we have been documenting for so long were not there anymore, because we were making it easier for them, through what I call the seeking mode. And just to give you a sense, the seeking mode actually is very valuable, because it is to intervene before the symptoms appear, or early when they appear early, and and preserve the normal function for as long as possible. So this is a response to prevent chronic health conditions or mental health conditions before they get even more complicated. And we have been
Sure.
we have several examples of that, you know, especially related to COVID, but beyond that, because the latest that we were doing is to go and provide on the spot where people live, where people work, where people congregated in community settings to provide, for example, blood, excuse me, uh, 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 blood pressure tests, and also screenings for depression. And we collected a lot of information about that in close collaboration with two community health networks or fairly qualified health centers, and with very, very promising results. So just to summarize, Dr. Lum, we have the technology now through digital health means to be able to do that and not to be waiting for people to really, really, uh, come for services when they are falling apart, because it will be too complicated by then. So if we catch that early in the process, I think we say, uh, along with the persons who are treated, a lot of prolonged suffering, is more cost effective, and it increases, improves quality of life. So this is something that we continue to be very excited about.
Thank you for that. Yes, it was really interesting, and it makes sense because when they present much more ill, it's a higher cost to the healthcare system, and it makes much more sense to be proactive, to care for these patients before they become severely ill. And what was
Yes.
really interesting to me was that uh, you would go, when you say go out into the community, go out to them where they live, work, play, etc. It really drives home the fact that you're being proactive, because people don't have time, which you mentioned. They can't take time off of work to go and take care of themselves, and so being able
Mhm.
to provide that, I think, is huge. One thing I wanted to kind of talk a little bit about that, um, and I know that you have plenty of experience, so it would be great to kind of share a little bit about how you've done it or succeeded, especially in a lot of these groups that are interested in providing these care, is being able to establish community trust
Yes.
in those areas. When you have projects or whatnot, companies, et cetera, are interested in doing things like this, how do you earn that community trust?
Mhm.
Because that's a huge uh, aspect of this.
Yes, I'm so pleased that you asked that question because we have been working on what is called now meaningful community engagement. That if we are to engage communities, and communities are not only for example, the community-based organizations, the community leaders, working with the agencies, working with law enforcement, with social services, with churches, with schools. Uh, the critical importance in all of that is, to build trust. And in order to build trust, we need uh, to listen attentively, and incorporate what we are listening to into whatever plans we 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 undertake, and to listen to what matters to those communities. But it is not only, the listening front and center for building trust. It is also something that absolutely we need to consider is to becoming ourselves as providers trustworthy, trustworthy, that the populations that we are serving trust us, that they are willing to receive the services from us because we have shown that we are trustworthy. And let me give you an example that has stayed with me and that captures what I'm telling you about. When we were providing free COVID tests and also vaccines, I remember going with my team to a migrant center close by. It's called Dixon Migrant Center. And I was very impressed, actually, to find out that some of the tenants in that housing uh, center were speaking in a first name basis with our promotoras or community health workers. I was very pleased to see that they were already, they had built trust. So one thing that I really still gives me chills to think about it, because I saw this mom bringing the 6-month baby, uh, asking if we could test him for COVID. And in my mind was, wow, that is trust. To bring a mother that is protected of a 6-month-old baby to be tested. And thankfully, the baby was negative. So our own community health workers or promotoras told her, you know, this time around, we are bringing free tests. But there is this other group from the county that are providing vaccines. Why don't you take your kid to be vaccinated? He's negative, so he can be vaccinated. And I was so impressed that the mother said, no, I'm going to be waiting until you bring the vaccines. That is trustworthiness. That really captures the how trustworthiness is fundamental to addressing health disparities or advancing health equity.
I totally agree with that. It's interesting as a surgeon, we have to deal with things like informed consent, surgical consent, and having the patient's trust is more important, something that's not intangible, more important than actually having a physical signature on a document. So I totally agree that and I think that, having, again, that patient-physician relationship really establishes and bounds trust. So trust is important. It's a key essential ingredient in all of this. I totally agree.
Yes.
One other, maybe a couple more questions I had. One was,
can I comment very quickly?
Sure.
I'm sorry to interrupt, because there are 3 contributions that I had been very much involved along with my center at the national level that really capture what I was talking about, the meaningful community engagement. That really, for those who are interested in this work, those are remarkable resources. One is the principles of community engagement that the CDC has been releasing since 1997 when they released the first edition. And then I work as the co-chair for the second edition, which was released in 2011. And just to give you a sense, the second edition has been downloaded from the CDC website about 10 million times. And it is available both in English and Spanish. And I took the lead to have the Spanish version. In this third edition that just was released this past January. Instead of being 9 principles as it happened on the first edition and the second edition, we added a 10th principle, which is trustworthiness as a fundamental element to advancing health and mental health equity. So that is one contribution. The other one is that had been working with the National Academy of Medicine for 6 years now, more than 6 years. I'm the co-chair, asked by the National Academy of Medicine on this work group that is called Assessing Meaningful Community Engagement in Health and Healthcare. And the National Academy of Medicine has released 5 resources, including a conceptual model on assessing meaningful community engagement. Also released 7 impact stories, which really are impactful. Based on a very comprehensive lit review, 28 instruments on community engagement, all for free. There is no gratuities, or there is no copyrights or anything. These are in the public domain, and also a user's guide. And we're working on the final report, which we are hoping to release early this coming year. The third one, and I'm going to finish with that, is the Association of American Medical Colleges Principles of Trustworthiness. The AAMC has been working for 4 years or so, and our center collaborated for a full year with the AAMC to evaluate the principles of trustworthiness toolkit that they developed. And now we have even a survey, trustworthiness survey, that is easy to use. So all of these things can be measured, and the way in which, in a way that we can document that it is possible to be trustworthy, or to be trust. That we build trust, something that wasn't readily available before. And I'm sorry that it took me this long, but I think that is important for the listeners to know that there are resources available to do this kind of work.
There you have it. So if and we have our own community engagement program called Operation Change. But for others that are also interested, check out the Principles of Community Engagement by Dr. Sergio Aguilar. And I think that is a wonderful, wonderful thing that our UC Davis Center for Reducing Health Disparities has produced. And we're so proud that you're, an icon and a legend in our little neck of the woods. And I'm so glad to have really highlighted some of the amazing and wonderful things that you have done. And it just really scratches the surface, because it's always great to talk to you, because hearing all the wonderful, fantastic things that you've been doing. So thank you so much. So to conclude, doctors. Oh, sorry. Go ahead.
No, on the contrary, Dr. Lum, I'm so grateful for this opportunity to share that information. By the way, the Principles of Community Engagement was released by the CDC, okay? And there were over 165 professionals who participated on that. And I'm one of the assistant editors, and I'm a co-author in 5 chapters. But there are many universities who have the book in their websites, and we'll be happy to send you these resources, Dr. Lum, to make them available.
Thank you so much. Dr. Sergio Aguilar-Gaxiola is the founding director of the Center for Reducing Health Disparities at UC Davis. Thank you so much for joining us today on the Health Disparities Podcast. That brings us to the end of another episode of the Health Disparities Podcast from Movement is Life. I'm Dr. Zachary Lum. Until next time, be safe and be well.